the phenotypes, choose the right drug strategy, as well as then apply it to your patient and to be able to get the adequate infection control. So the key shift that has happened in carbapenem resistance is not just based on the MIC. It is basically the mechanism driven, which actually helps you bedside to decide your therapy. It matters because it is associated with high mortality. If your empiric carbapenem fails to cover for NDM, OXA, or GRAB, and if they dominate, then your therapy that you've chosen empirically will be ineffective. Now, colistin only strategies. Again, these days it is more and more recommended that you choose colistin sparing strategies when the alternatives like Cazavi are available. Also, because it is associated with higher nephro and neurotoxicity. So, you need to keep these things in mind when you're choosing your drugs. So, let us begin with understanding the mechanism of carbapenem resistance. The key routes which lead to failure, the resistance mechanisms, are your enzyme destruction, access problem, target change, and drug modification. Now, when we look at enzyme destruction, your beta lactamases hydrolyze penicillins, cephalosporins, and carbapenems. Access problem, loss of pore channel. It will prevent your drug from entering. Efflux pumps will push your drug out. Target change, the PPPs and ribosomal changes will reduce the drug binding. And then drug modification, that is aminoglycoside modifying enzymes which will totally inactivate the drug. So these mechanisms again need to be kept in mind. So when we talk about the key enzymes and the resistance mechanisms, we talk about the Ambler classification. And there are 4 classes of the Ambler classification, that is class A, B, C, and D. In A, you have your KPCs, GES, SME, IM, and these are the serine carbapenemases. B is your NDM, also has VIM and IMP, which are the metallo beta lactamases. C is the AMC, and then D is the OXA 48, OXA 23, 24, and 58. So beginning with class A, the ESBLs, we come across TEM, SHV, and CTXM. There are other variants as well. What do these do? What do they tell you? They drive the ceftriaxone cephalosporin resistance, and you have to remember that this may coexist with carbapenemases. Class A carbapenemases, we know KPC is the commonest. There are GES variants as well, which may behave as ESBL or carbapenemase. And the therapy which is effective is the newer BLIs, that is avibactam, which is available, and the others which are not, the relebactam and the riborbactam. Now, KPC, like I said, is common but is not common in our Indian ICUs. It is important to recognize because it is not inhibited by clavulanate, sulbactam, or tazobactam. It is inhibited by the newer BLIs, and KPC mutations can also cause ceftazidime and avibactam resistance. So in that case, the mechanism testing and repeat AST become essential. So unless you know about this, you wouldn't actually test. I also talked about the GES. So in this, there are 2 possible phenotypes, like the ESBL or the carbapenemase. So the gene label is not enough. It is the variant and the phenotype that actually, decide what you choose bedside for your patient. Then the second class is your class B, which is your metallo beta lactamases, namely the NDM, IMP, and the VIM. So now they need zinc, and they are not inhibited by the avibactam, rele, and riborbactam. Astronam is stable to the metallo beta lactamases, but it is destroyed by co-production of the ESBL, AMC, and OXAs. So when you are giving this for the ESBL, you will have to use the Astronam and avibactam strategy. So then for this is what would be the preferred strategy of choice, Astronam and avibactam, when you know that it can be destroyed by co-production of ESBL, AMC, or OXAs. Then this is just to show you that over time, like you can see the red part, the Indian on the map, endemic spread of NDM producers has been on the rise. And once you have detected NDM, you need to have the MBL strategy. we just talked about it. So ceftazidime avibactam and astronam or astronam avibactam, cefderichol if it is available, not in our country. Then, like I said, now this is where you want to avoid colistin because you have other options available and you have an active beta-lactam. But do not choose the drug blindly. It has to be integrated with the syndrome you are treating and the PKPD, the dosing as well as the source control. Then the others are the IMP and VIM, which are important in cases of Pseudomonas and some Enterobacteriales. They are not inhibited by the newer BLIs. Then class D, the OXA enzymes. So now when we talk about the OXA enzymes, we see OXA48 commonly associated with Enterobacterials. The others, OXA 23, 24, 51 and 58 are all associated with Acinetobacter. And in these, your avibactam is not going to be effective. So when you see this, you need to know what you're dealing with. And from 23, 24, 51 and 58 are all associated with Acinetobacter. So this was actually shared by Dr. Prakshit Prayag, and this was a study which was published in the IJCCM in 2023, which was basically a retrospective analysis of the ceftazidime avibactam with or without astronam versus polymyxin-based combination therapy for carbapenem resistance enterobacteriaceae. So in the Indian ICUs, we have been getting OXA48 and NDM or NDM alone. So based on this also, if you see for Klebsiella pneumoniae, they found that OXA48 and CTXM was the predominant one, followed by OXA48, CTXM and NDM. Similarly, if you look at E. coli, the predominant resistance was seen with NDM and CTXM, and then then the second one was NDM. We do see quite a bit of OXA48 and NDM as well. Similarly, for crab, if you see, again, OXA23 and OXA51 were the predominant ones, and again, OXA23, 51 and NDM. So, in the Indian ICUs, we are seeing a lot of these, and you need to know which one is actually for which underlying gram-negative bacteria. So, to summarize, how do these local enzymes derive the pattern and the treatment choice? For CRE, we know that NDM and OXA48 dominate, and co-production we know is common. So ceftazidime avibactam alone would be an inappropriate therapy because then you're not covering for if the NDM is positive and you're not giving therapy for that. Similarly, in cases of crab infections, OXA 23, 24, 51, 58 are common, and NDM can coexist. So this is where your sulbactam-based strategy, along with polymyxin as a combination therapy based on the AST, is your treatment of choice. For difficult to treat Pseudomonas, we know that there are multiple mechanisms. There can be porin loss, efflux pumps, AMP-C, as well as metallo-beta-lactamases in many isolates. So the mechanism is often mixed. So that is why it becomes difficult to treat, and your therapy has to be according to the underlying problem. Since I was talking about Pseudomonas resistance mechanisms, we know that Pseudomonas resistance can be because of efflux pumps, because of loss of porin channels. Porin channel loss would reduce the entry of drugs like carbapenems, especially IMI and meropenem. Efflux pumps would reduce intracellular drug concentration, and AMP-C expression can pair with porin loss and efflux. So the phenotype may look resistant even without a carbapenem-based gene. This is why Pseudomonas becomes a difficult to treat bug. Then one of the emerging mechanisms that is recently being talked about is the penicillin binding protein 3 inserts in E. coli, which can reduce the activity of some beta-lactams, and this is specifically relevant if the NDM coexists. So your astronam-based strategies will be not effective. So if you've chosen an astronam-based strategy and you're not getting the desired response, you may have to, recheck with your lab the underlying mechanism and recheck the susceptibility confirmation, because this is one of the emerging mechanisms in E. coli. So you have understood the Ambler classification and you've seen the genes. So before and you've chosen an antibiotic, you started the patient on certain antibiotics, and you're not getting a response. So don't just jump on to changing the antibiotic because your sensitivity report is telling you that this is another one which is possible. Recheck the syndrome. Look, is there a compatible infection? How severe is the infection? Is your patient stable or is he in shock? Are you dealing with an immunocompromised host? Did you achieve source control? Did you remove that infected line? Then the underlying mechanism, the MIC of the drug that you chose. And if you have chosen a particular drug, does it penetrate the site of your infection? Or have you just chosen it based on the AST report that was given to you? Because all this will actually determine your response to treatment. So how do we detect this in the lab? And how do you clinically interpret? So the carbapenem resistance we know has exceeded about 40%, and this data is from 2017 and 18, which you understand has increased much more. And OXAs and NDM enzymes are the predominant carbapenemases in India. So when we look at phenotypic and genotypic tests, the molecular diagnostic tests for antimicrobial resistance testing, they detect the acquired genes. And the resistance gene may not be expressed always. So you cannot always reliably predict the phenotypic resistance. And genotypic testing may not detect all mechanisms like AMC, flux pumps. And phenotypic antimicrobial resistance diagnostic, they test the ability of the bacteria to grow in the presence of specific antimicrobial agents. So let us understand this as we go ahead. What is phenotypic and what is genotypic? To detect antimicrobial susceptibility testing, the common methods first that we use to detect this is dilution-based methods like the agar dilution, the macro broth dilution, the microbroth dilution. Then you have disc diffusion, which is diffusion-based, disc and gradient diffusion. Then automated systems like Vitek2, we have this in our setup. There is also Sensitire and BD Phoenix. So this is basically to show you the methods of MIC determination, the broth, macro and micro dilution, agar dilution, gradient diffusion or the e-test, and the various automated machines that are there to detect MIC. So beginning with the disc diffusion method, which basically interprets to the zone of diameter and the breakpoint. So what happens is that you can see an agar plate here in the picture, and you know that when this is the way the bacteria are spread evenly on the agar, and the antibiotic discs are diffused into the agar. So you can see a clear zone of inhibited growth. This zone is measured in millimeters, and it is compared with the breakpoint table. If there is a larger zone of diameter, that means that there is more growth inhibition around the disc, and it usually corresponds to lower MIC. But it may become susceptible if it is above the zone breakpoint. We'll understand this again as we go ahead. Small zone diameter would be less growth inhibition around the disc, usually corresponds to higher MIC. It may become resistant if it is below the zone breakpoint. So remember that it is not your visual impression that you've seen that there is a larger diameter of inhibition or a smaller diameter. It would actually depend upon the breakpoint, which will decide whether your bug is sensitive I or R for the particular drugs that you've tested for. So then you have the broth, macro and micro dilution methods. So as you look at this, you can see that this is the broth micro dilution, and you can see that at 4 microgram per ml, there is complete inhibition of visible growth of the microorganism. So this is basically your broth macro dilution, which has the microplate wells, and in a similar way, it detects your and gives you your MICs. Then we have the gradient diffusion, the E-test, wherein you have the strips which with the drug gradient which is put on the agar, and again this is how it looks, and it gives you the MIC. Then we have the automated systems. Now, there are various, like I told you, Vitek2, BD Phoenix, even the Sensitire, but the way the sample is processed for the automated systems is that once you have a growth on a culture plate, a pure isolate is picked up from a fresh colony. and then the inoculum is standardized to a defined turbidity or instrument verified density. Now this organism suspension is loaded onto the cards, panels or wells which contain antibiotics. Now once it is put into this automated system, it would incubate and read the growth signals over time. And then it's the software, the automated software that converts the patterns into identification, and it would give you the susceptibility results, the MICs. So that is how your Vitec2 works. So an integrated workflow for a blood sample when you've taken and sent it to your lab would look something like this, that you send the sample and it was processed and put into the word point is lower, which tells me that this is a resistant. So this drug will actually be ineffective. So you cannot select just based on the MIC, because it can still be resistant if the breakpoint is even lower, as in this case. Now you see that from this report you have two drugs. So which one would you select would depend upon the breakpoint to MIC quotient, which is the BMQ, that is susceptible breakpoint by the patient isolate MIC. As you can see, for drug A it is 8 and for drug B it is 2. So higher BMQ suggests more pharmacodynamic space, but again you do not just blindly depend upon the values. You see what site of infection you are treating, the dose, whether you've achieved source control, and the also monitor for the toxicity. So I've been saying SI and SDD. What do they mean? S is the high likelihood of success with usual dose. I from UCAST means susceptible with increased exposure. I from CLSI means intermediate or possible at high exposure or concentrated sites. Then SDD is susceptible dose dependent for defined bug-drug pairs and likelihood of therapeutic success if exposure to drug is increased by adjusting the dosing regimen. And R is again the high likelihood of failure even with exposure. So you need to know what you are actually looking at from the report. Why do these breakpoints change over time? Because new PK/PD data keeps evolving, new resistance keeps developing, the outcome data keeps changing. So breakpoints need to be revised. Like I said, they are released every year from UCAS and CRSI, and they have to be, your lab has to update them. If there are no valid breakpoints, so you report the MIC without SINR. That is the basic thing that you need to remember. So you've got your reports. So now there are tests which basically detect the genes, the mutations, which can be genotypic or phenotypic tests. Now genotypic tests would detect your genes or mutations that you were just talking about. And they give you faster results, especially in your critically ill patients when you want to start early targeted therapy. Phenotypic tests would assess the growth in the presence of antibiotic, and they are slower but they are essential for final therapy. So these are the various rapid tests that are there, like the CABA-NP and the Malditov hydrolysis. Then we also have the CABA-5 expert CABA-R and the film area of the biofire. So beginning with the phenotypic carbapenemase assay, the CABA-NP that I just told you about. Now this would detect the presence of carbapenemase active. Okay, this would not detect which carbapenemase, which gene. So you know what, this is basically based on the color change, and as the carbapenemase gets hydrolyzed, the color changes to this yellow color, and it detects the presence of carbapenemase activity. But which gene is responsible for the resistance, it will not tell you. Then there is a Rapidtech CABA-NP. So it has a phenol red pH indicator over here, and you're using you've used a carbapenem substrate like imipenem, and this requires zinc, like I told you, for detection of the metallo-beta-lactamase producing strains. So once you've inoculated the sample and you put in on this CABA-NP, it will change the color. As you can see from the red, it has changed to orange, and then it changes to yellow, which tells you that the resistance is present. Then Malditov. Now again, this would help you to detect carbapenemase. It will not tell you which one. these are two wells, and you can see that the first one has E. coli with meropenem and the other has Klebsiella pneumoniae with meropenem. Now, if there is production of carbapenemase, like you can see here, for example, KPC, this is detected by the machine over time based on these peaks and the molecular weight. The change that occurs with the detection when there is carbapenemase present, it is detected by the machine based on the molecular weight of these peaks, and it tells you whether the carbapenemase is present or not. But which one, it will not tell you.
So in future the problem
then we have the CABA5, which is based on the lateral flow immunoassay. And what would this detect? Like I told you, the previous ones that we just talked about would detect carbapenemase activity. Now, which targets would be detected by tests like the CABA5, like your KPCs, NDM, WIM, IMP, and OXA48. The advantage of this is that it is faster turnaround time. It helps you to start early target therapy. And this you can see, once you have a pure colony, it is processed based on the manufacturer's recommendation. It is processed, and the recommended drops are then put on the this this cartridge, and then it gives you the resistance, whichever is present. Similarly, it can also be done directly from the blood culture bottle. Once you have a positive blood culture, it is processed again based on the manufacturer's recommendation, and it is again put on the test to give you the to detect the resistance. And as you can see that it has a very high specificity and sensitivity of 97 and almost 96%. Then we have the molecular tests. Now we have been talking about these molecular rapid tests quite a bit, and you all understand that these are PCR based tests. We commonly use the multiplex PCR, like the respiratory viral or the pneumonia panel. Pneumonia useful when pathogens can cause this, when you have many pathogens causing the same syndrome. Then we also have the PCR-based syndromic molecular panel, like your pneumonia panel, BCID panel, meningitis, encephalitis panel, or the GI panel. Now, these multiplex PCR, these syndromic panel molecular tests, they not only identify the bugs, they also give you the genes which are responsible for the resistance in the same test. So it would help you to start early targeted therapy most of the tertiary care centers. The advantages, like I said, they identify very quickly these rapid diagnostics. So naturally you will be able to start your early targeted therapy, and they are not less affected by the prior antibiotics than culture alone. And they can also not only start early target therapy but appropriate de-escalation as well. The limitations are that the panel size is limited and polymicrobial samples can be difficult. And remember that despite of these rapid diagnostic tests, we have been talking about this often, that conventional culture and AST confirmation is always needed. So do not substitute these rapid diagnostic tests with conventional culture and AST. You have to send that for all your patients. Now, a lot of times you look at a resistance pattern on the report, and if you look at it carefully, it might help you interpret the resistance mechanism. Like, look at the first sensitivity report, and when you look at this, you see that it is resistant to most of the drugs except, and it is sensitive to ceftazidime and imipenem. So when it is sensitive to, and you see that it is resistant to meropenem here, it is sensitive to IMI but resistant to mero. So this tells you that there is a possibility that the mechanism of resistance over here is efflux pump. Let's look at another report. Now you see that this particular bug is resistant to all the drugs and is only sensitive to omecacin, which tells you that the possibility of the resistance mechanism is probably combination, and not just efflux but also enzymatic degradation is what is happening here. Then when we look at the third report, you see it is sensitive to most of the drugs except for meropenem and imipenem. So just by looking at the report, you can sometimes understand or interpret the resistance mechanism. So particularly here, when it is resistant to imipenem, it tells you that there is probably loss of the porin channel. So to summarize, when you have the carbapenemase detection with rapid phenotypic lateral flow assays or molecular tests, you either have your enterobacterials which are detected, or you have your non-fermenters like Acinetobacter or Pseudomonas. Now, for non-fermenters, we rely more on the polymyxin-based combination therapies like we just discussed. For enterobacterials, it can be your carbapenem-resistant Klebsiella, it can be a carbapenem-resistant E. coli. Carbapenem may not be detected or rapid test may not be available. So when you have a Klebsiella which is resistant, it is either going to be OXA48 or KPC. So for an OXA48 or KPC only, you can de-escalate to Cas-AVE monotherapy. And for an OXA48 with a metallo-beta-lactamase, you test for synergy and between the Cas-AVE and the aztreonam, and that is the combination that you have to consider. So your your therapy of choice becomes Cas-AVE plus ATM. Then for carbapenem resistance E. coli, there is metallo-beta lactamase, may or may not have OXA48. Again, like I said, you need to do synergy testing and you need to check for both. So if it is present, then your therapy of choice becomes Cas-AVE plus ATM, and if it is absent, then you need to think of possibility of PBP3 inserts that I was just talking about. And then your therapies that you will have to consider would be polymyxin B or fosfomycin in this particular case. If you do not detect carbapenemase, so you continue Cas-AVE plus ATM until you get your phenotypic susceptibility. Like I said, you have to send your phenotypic test for all your patients. And similarly, if the rapid tests are not available and you've started, so you continue the therapy unless your phenotypic susceptibility reports are available. Once they are available, you correlate the results with the susceptibility and de-escalate. So you de-escalate if for non-carbapenemase producers, otherwise you continue. So what are the common errors to avoid? Treating every S result as clinically suitable. You do not blindly rely on the report. You have to correlate it clinically with the syndrome. You have to see the site you're treating, the PK/PD, and you have to integrate everything together before choosing your drug bedside. Using Cas-AVE alone for an NDM producer, we just talked about this. You have to add cover for NDM. Then ignoring OXA48 plus NDM co-production. Then equating gene negative with mechanism negative. It is not necessary. Both of them can coexist. If the gene is negative, there could be another mechanism which is causing resistance. So you cannot just rely that the genes are negative, so this patient is susceptible. You will not achieve the desired outcome. Then forgetting site penetration and source control. I just talked about this. I think I've told enough about the source control and site penetration. And continuing broad therapy even after the final AST. Remember, there is a risk of AMR. It is on the rise. It has only been increasing. So unless you understand that you need to de-escalate, stop, preserve your antibiotics, this problem of antimicrobial resistance you'll never be able to overcome. So the final algorithm from positive to action looks like you have a positive gram-negative bacteria from a sterile site. You assess the severity. Look at your patient. Do you really need to change that antibiotic? Does this particular report is telling you that there is a high possibility of MDR risk, or does your patient have the possibility that there's a high chance of multi-drug resistance? Then you have your rapid test for identification, and they give you the antimicrobial resistance markers. You choose the therapy based when you match it to the mechanism. Once you get your final AST report, you correlate it with the response and the drug that you chose. And of course, you have to achieve source control to be able to reach here and get the desired outcome. And then you de-escalate once you have the final report so as to prevent spread. So, a best clinician would integrate the clinical syndrome, the microbiology, as well as the pharmacology together, and not just rely on the report and jump onto selecting an antibiotic. We all understand that carbapenem resistance is not one disease. You need to identify the mechanism, match the drug, control the source, and de-escalate early. Thank you.
Thank you, Dr. Kamsha, for giving a wonderful presentation. Actually, that was a very nice talk. You have a lot of summarized, and we're going to hear more about this in the talks today. So I have a great pleasure in introducing Dr. Abdul Ghafoor, who is going to moderate the session today. I know Dr. Abdul Ghafoor for many years, and he is one of the person who has been after antimicrobial resistance almost like 25 to 30 years. He was the coordinator of the Chennai declaration on antimicrobial resistance, as all of you can see. He is MRCP and FRC path. He is currently working as a senior consultant, infectious diseases at the Polo Hospital, Chennai, management trustee of the AMR Declaration Trust, managing partner, Forum Veda Consulting Services. He's actually involved in academic and policy initiative on AMR. He's been jury member, longitudinal prize on AMR, and widely published in leading journal, including the Lancet and BMJ. So, over to Dr. Abdul Ghafoor to conduct today's proceeding.
Good evening, Dr. Chawla.
I'll just put the introduction of. You can go ahead. Keep on.
No, we can just put the introduction of Dr. Todi. Yes,
Dr.
joined.
Sayan.
Dr. Sayan is going to be, yes.
Dr. Sayan.
Age कितना है?
30.
Yeah. Good evening, Dr. Chawla. Thank you very much for inviting me. You have been doing this in excellent academic sessions every week. That's an amazing job. And it's a very important topic too today. And we have Dr. Sayan Chakravarti today as the next speaker, Consultant Department of Infectious Diseases, Manipal Hospitals, Kolkata. And Dr. Sayan, he has been the gold medalist, AIMS DMMCH entrance examination, and multiple publications in peer-reviewed journals, and so many textbook chapter. Has been speaker on many international conferences and symposiums, and he has been the organizing secretary of SwissCon 2022, AmriCon 2023, and he has contributed to many guidelines, and including dengue guidelines for the West Bengal government, and national brain infection guidelines, and he has been a member of the COVID task force, AIMS New Delhi, and he's a member of the CRCCID, our Infectious Disease Society, and also Infectious Disease Society of America, and he's got a special interest in critical care infectious disease, fever of unknown origin, and infections in immunocompromised host, travel medicine, adult vaccination. Dr. Sayan, over to you. It's waiting for your excellent talk.
Thank you so much, sir, for the lovely introduction, and good evening, everyone. I'll just share my slides. Okay, is my slide visible?
Yes.
Okay. So the topic of discussion will be management of DTR gram-negative pneumonia. So regarding difficult, so this is a new definition that is being used mostly for the pseudomonas infection. So what is actually this definition? Difficult to treat, and we really need this kind of new definition, because we already know that there is something called MDR, there is something called XDR and DTR. So let's just difficult to treat infections is actually resistance to the first line agents like the beta-lactams and the beta-lactam inhibitors, carbapenems and fluoroquinolones. So DTR always have a very specific kind of resistance to these particular classes of antibiotics. Now, if I talk about MDR, the MDR resistance is to more than 3 classes. the classes are not
ये
specified.
संडे नहीं रहेंगे हम
XDR is susceptible to
ये
one
16
or
तारीख को
two
नहीं
classes
रहेंगे
only.
11 को
And
रहेंगे
DTR, the band drug resistance, is resistant to all
शनिवार
classes.
रहेंगे सेम
So,
10:30 से
in
11:30
DTR, XDR
2 बजे तक
and MTR, the classes are not specified, but in DTR, there are very specific classes. So that's why there is an importance to this particular nomenclature. Now, as already been discussed, what are the various etiology of the GNP pneumonia? So the most common ones, the part of the escape group of organisms, Klebsiella pneumoniae, Acinetobacter, Pseudomonas, and E. coli. And if I talk about the lesser common one, maybe what we call as the atypical ones in our common parlance, the Stenotrophomonas, Serratia, Bartholdoria, and Chrysobacteria. These all, and there are many others, which can be the etiology of the gram-negative pneumonia. So I will be discussing 3 cases. So all the 3 cases are of different types. The first case is a bit long case. So the patient had a very long stay and it was a very difficult to treat infections multiple times. The second case is a very common case and a very common mistake done by most of the people, most of us do it. And the third case is a very difficult organism. So I'll discuss these cases in bit details. So the first case, a very unfortunate lady, she delivered a baby at 38 weeks. She developed a severe postpartum hemorrhage. For that treatment, uterine artery embolization was done, it failed, hysterectomy was done, and later on she developed a postpartum cardiomyopathy. She developed features of severe ARDS, put on mechanical ventilation, did not work that much. She was put on a veno-venous ECMO as well. Eventually, the series of infections now starts. So she developed a UTI with a ESBL coli. So I'm not going into the details of she developed a fever and there was a rise of CRP and with all the cultures and that. So I'm just going straight to the point. She developed a UTI with a ESBL E. coli. It was treated for meropenem and the right dose with the right duration and it got cured. Later on, again, she developed some fever and all, something happened, and she was diagnosed as a lower respiratory infection, probably a VAP, and this time it was a carbapenem-resistant Klebsiella, treated with ceftazidime avibactam, which was susceptible, and so it resolved. So patient was somehow doing well for that time. The patient was still on ECMO, and while the patient is on ECMO, you know that there is increased volume of distribution. So the dosage of the antibiotics have to be according to the dosage requirement for ECMO. Okay. So later on, now the patient developed oliguria AKI, developed anuria, put on dialysis. Now Pseudomonas came into the picture. She developed again a VAP with carbapenem resistant Pseudomonas. It was treated with ceftazidime avibactam with the astrodome combination. So that responded well. She was weaned off from ECMO and her dialysis was continued. So eventually she was put on tracheostomy with minimal oxygen supplementation and she was doing quite well. All the infection control strategies were put on place, but still these infections kept on coming. Again, she developed a lower respiratory infection, and this time it was a DTR pseudomonas. So it was resistant to the fluoroquinolones, obviously, carbapenems, and the BLBLI combinations. So again, she was put on mechanical ventilation. So this time she was put on ceftazidime avibactam, astronam, and a polymyxin B combination, and she responded quite well to that. So her oxygen requirement came down, and she was again put on these with the supplemental oxygen. So she was doing well. This time a new onset UTI happened, which was awaited. So this time it was a enterococcus species. She was started on picoplanin, and again she responded. Now she has been on so many broad spectrum antibiotics, and the thing that usually happens when you put on a patient with not many antibiotics is a new onset antibiotic associated diarrhea, and it was diagnosed to be as a C. diff diarrhea. She was started on capsule vancomycin and she was started recovering slowly. She was recovering quite well after that. Now this DTR pseudomonas came back again, so it becomes a problem now that pseudomonas once gets inside the lungs, and it is going to stay there for quite some time because the lungs get damaged and the Pseudomonas loves that damaged lung. So the patient was this time started on plazomicin with polymyxin B. So plazomicin is not really a good choice for Pseudomonas, not really a good choice for lung infections, but there are certain studies about it. I'll show you. Okay. So she was started on polymyxin B and plazomicin. We had actually ordered for cefepime zidebactam, but by that time it was not available at that time. The patient's relative had to apply to the central government, CDSCO, and also that was a huge problem. But we were waiting for cefepime zidebactam to come. But by that time, we need to keep the patient alive. So anyway, by this combination, the fever decreased and the TT secretions also decreased. There was decrease of the inflammatory markers as well. Patient maintained the oxygen saturation and she was put on room. However, the dialysis had to be continued and it could not be stopped. And it responded quite well. The patient was free of infection for around 1 week. So we are quite lucky about that. So just to tell about the particular trial regarding plazomicin. So I will be discussing some few drugs which can be used in these DTR cases once you are short of antibiotics. So this particular trial was published in NEJM. So this is actually a correspondence to the editor. And they had kept around 39 patients of PSI, HAP and VAP cases where they had compared plazomicin versus polystine. So cases were really less. But anyway, so they actually got good data out of it, and death from any cause happened in 14% cases who had plazomicin and 53% cases who patient on polystine. So overall, this data actually showed some hope that plazomicin can be used outside the urinary tract in the bloodstream infection and in the lung infections as well. Side effects was less and overall nephrotoxicity was also less as compared to the polystine. So this is what this clear trial showed. And if we talk about some meta-analysis of the RCTs, so there were 3 RCTs done consisting of 761 patients. They had complicated UTI, bloodstream infections and HAP. The clinical remission rates were similar. Eradication rate was also similar. Microbiological recurrence was also lower and no significant difference in the adverse events if you compare with plazomicin with other standard of care drugs or polystine. So this meta-analysis showed. So plazomicin is one of the drugs that can be used in DTR cases if it is susceptible. Yeah, but you definitely have to check whether by the E-strip whether it is susceptible or not. So we did that and we found that Pseudomonas is susceptible. So the patient was well for 1 week, but again this Pseudomonas came back. We got hold of cefepime zidebactam. We used that. The patient got better. Again the Pseudomonas came back. We had to use cefepime zidebactam with astronam combination. Then patient was again doing well for around 1 week. When patient started eating by her own, things got better, but Pseudomonas did not leave us. It became our biggest enemy. This time we used cefepime zidebactam with astronam and polymyxin B combination. So you can understand what the patient was going through and what the treating team was going through, because we could not take her out of the ICU and the patient was there in the ICU and these infections were continuing. So unfortunately, she succumbed to her illness, but we used so many drugs and this cefepime zidebactam, the newest drug, is going to be launched very soon. It was initially given the emergency use for Pseudomonas, but again, once they are launched, you can use it for these DTR kind of patients. So this cefepime zidebactam is actually a beta-lactam enhancer. It is not actually a beta-lactam inhibitor. It is a beta-lactam enhancer. It has got a potent activity against PVP2 and it also protects the cefepime from hydrolysis by certain enzymes. And cefepime has got a strong PVP3 activity. So these two, cefepime and zidebactam together, they will be attaching themselves to PVP2 and PVP3. So that's why they show a very strong synergy. So that's why this is very important. And like Dr. Ansha was discussing about the PVP3 mutations, here the zidebactam is going to potentiate the cefepime by acting on the PVP2. It has got that activity as well. CLN has already endorsed it. There is apparently no cross resistance. Okay. There is another molecule, cefepime taniborbactam, which usually doesn't work with IMP, and the cefiderocol which is I'll be discussing again. So this is another drug which can be used in this Pseudomonas and coli and all, but it also fails in some compounds and polymer channels. And we were thinking that probably Cefepime-Zidovectam is the molecule of the future and it cannot get resistant at all, but which showed that Cefepime-Zidovectam can become resistant. The culprit was a new mutation in the efflux pump, and there can be some cross resistance to Imidacloprid and the Ceftazidime-Avibactam. So it is not like a foolproof molecule. Whenever you are using it, you have to use it for these DTR cases, and you have to be very much like careful while using this particular molecule. You cannot go and abuse this molecule like we did to piptaz or meropenem. And there is another molecule like ceftolozane tazobactam. This can be used for this DTR pseudomonas, and mostly the activity is for ESBL and AMS. And there are other options as well, like PAS therapy, which is mostly in research right now. We don't have much of experience in using directly on the patients. There are certain immunotherapies like this monoclonal antibodies and panobactamab and all. And there are certain newer beta-lactamase inhibitors that are coming like nacobactam and taniborbactam. And there are certain antimicrobial peptides which are under study and research. Okay, so that was one case regarding a difficult to treat pseudomonas where we had used all kind of antibiotics which can be used, and eventually the patient succumbed because that pseudomonas became like a superman or something. Okay, so this is the next case, a very common case. It's a elderly gentleman, diabetic hypertensive, and he presented to the hospital with a hemorrhagic CPA. The patient was admitted in the neuro ICU, and patient had a decompressive craniotomy, and the hematoma evacuation was done, and the patient was put on mechanical ventilation. So after a few days, the patient developed a new onset fever with increased FiO2 and P. Chest X-ray showed a left lower lobe patch, and there was a rise of inflammatory markers. So that was a diagnosis of ventilator-associated pneumonia. A bronchoscopy was done. Patient was started on an empirical meropenem and teicoplanin. So the bronchoscopy culture showed intermediate to colistin and resistant to minocycline. Now, so this is the data that is available to us. So what are the treatment options? So you can use a high dose sulbactam with a high dose tigecycline. You cannot use a normal dose tigecycline in this case. You can use a high dose sulbactam with polymyxin. And if it is a very severe case, if it is really difficult to treat, you can use a combination of these three: high dose sulbactam, high dose TG, and polymyxin. So regarding tigecycline, so if you use tigecycline in a normal dose and also as a monotherapy, so there are studies which are showing a higher mortality. As per this particular study, higher mortality in tigecycline versus the comparator group. And as per this study, US FDA has given a black box warning for the patients who are having a VAP, and they have been given tigecycline, so there can be a higher mortality. So this thing has to be kept in mind. Tigecycline has got a decreased bioavailability in the lung. So whenever, if you have to at all use it, you have to use it in a higher dose with a combination. So in this case, we started a high dose sulbactam with a polymyxin. The fever subsided and the counts have started decreasing, and the patient got better and eventually extubated. So high dose sulbactam and polymyxin combination can be used for carbapenem-resistant Acinetobacter. If the minocycline is susceptible, so high dose sulbactam with minocycline would be a better choice, because you can avoid polymyxin in that case. So that combination is always better, but in this case the minocycline was raised. Now the newer molecule, that's sulbactam and a darlobactam combination, which is not available in India right now, but this is a good combination. Here, as per the ATTACK trial, this can be given as a 1:1 ratio, 1 gram plus 1 gram in a 3-hour infusion. They have shown it has got a decreased mortality, and the studies also show a good favorable outcome in this particular combination, sulbactam darlobactam with the imipenem combination in this ATTACK trial. So sulbactam actually works like an antibiotic by itself for Acinetobacter. It targets the PP1A, 1P, and PP3. And in this study, imipenem was used, which targets the PP2. And darlobectam acts against the class A CDP, the Ambler classification was Dr. Akansha was talking about. So it can act against these particular class A CDP class of genes. So action is against OPSA 23 and 24 and 40. So this particular combination works really well for the acinetobacter. Cafidolocol, initially it showed a lot of promise, it was kind of a sort of a game changer, but actually the studies have shown that it is not really that molecule that we were looking forward to. So you can use it for refractory cases. You need to use it in combination. Better to avoid in carbo-resistant acinetobacter. Yeah, you can try it for enterobacter, but specifically in combination. It is not still available in India right now, but we have used it before for different cases where it was really difficult to treat and we got some response. And regarding organ penetration, so like was being discussed in the previous lecture, that source control and the penetration of the antibiotics is very important. Like you can see that minocycline has got a good penetration in the lung and bloodstream, not so good in CSF and not so good in urine. Tigecycline has got a lung penetration if you're using in a higher dose, very low bloodstream penetration, CSF penetration, and is not that good. Tigecycline should better be used for intra-abdominal infections and skin and soft tissue infections. Sulbactam is overall good, not so good for CSF. Polymyxin B, okay for the lung, for bloodstream. Polystyrene might be a little better for polymyxin B. CSF, polystyrene and poly B, those are not actually good. You have to give it intrathecal or intraventricular. And urine polystyrene has got a good penetration. Okay. So moving on to the next case. So it was a very difficult organism basically. So 65-year-old lady, diabetic, hypertensive, and rheumatoid arthritis on DMARDs. Now presented with the acute onset shortness of breath, fever, and rapid expectoration. Now workup was done, and she was found to have a RA-associated ILD and also a community-acquired pneumonia with a strep pneumonia. So she was started on ceftriaxone, which she was not really responding well. So the ceftriaxone was changed to ceftaroline, and she responded. She was there in the IC for some time, and she got a new onset fever. Now there was a new onset cough with expectoration. Her oxygen requirement also increased, and inflammatory markers also increased. So since she was producing sputum, we sent it, and there was a growth of Burkholderia capaci. Now it has become a difficult to treat because it was intermediate to ciprofloxacin, levofloxacin. It is resistant to minocycline, cotrimoxazole, meropenem, and ceftazine. Now, in this scenario, it becomes really difficult which antibiotic to choose. Okay. Now, what are the treatment options? So, you can give ceftazidime, avibactam plus minus astronam, which we are not sure whether it is going to work or not. Or you can try with a multi-target combination of antimicrobials because you have to use different antimicrobials together. Now, we tried ceftazidime, avibactam, astronam. So, it was resistant. Firstly, ceftazidime was resistant, and there was no synergy also with this combination. So now we were in a fix. Now what to use? Because she was already having a bad lung. Burkholderia capacia is known to stick on in the bad lung, and this becomes a nightmare for them, especially with the pulmonologist.
They gave prescribed some medication.
Now, we chose a very weird kind of
medication.
antibiotic strategy. Cefepime and metazobactam with astronam and a high dose ciprofloxacin. Now there is no specific justification to use this particular antibiotic regimen. The reason we chose is that because cefepime and metazobactam has a high molecular weight and a bigger size. So Burkholderia capacia is known to produce efflux pumps, and with a combination of astronam and a high dose ciprofloxacin, so that we can use antibiotics with a different responded to this combination. Changed this combination after she responded because she subsided and her CRP dose also decreased. Okay, so luckily this combination really worked, and we continued it for around 10 days, and after she came out of the ICU and she got discharged. So we talk about the various reports and studies. This was published in transplantation reports and multi-target combination antibiotics as salvage therapy for severe infection by ban-resistant Burfordillia following a lung transplant. So this was even difficult as a case. So the patient here was treated with a combination of ceftazidime, avibactam, ciprofloxacin, meropenem, minocycline, sulfatazine, and tobramycin. So you can see there are around 6 antibiotics used for this case, and the patient responded because different combinations were being tried. Okay, so probably you can sometimes use this kind of combinations. I don't know how rational this combination is, but in these cases, the difficult resistant cases, sometimes we have to use this kind of combination. So I chose that combination because of the molecular weight and the molecular size, which might be helpful in that case, and it worked.
Salt
So
water.
regarding the final take-home messages,
Salt
I'll just
water means
finish
you have to add
off.
salt in the common
So
water.
MDR, HDR,
In vessels you have to make hot
sometimes
water.
we do write in our notes, but this
steamer and all
doesn't
it
give
will
us
not work.
any idea whether
Clean,
this
na?
particular organism is susceptible to the
These-
carbapenems or not. Sometimes you can put
Any
in
medicine
a
allergy?
nomenclature of DTR or simply
Acid,
carbapenems.
any other
So that
medicines you are
helps
taking?
No.
in the approach while you are treating the patient. And even in this era of this
So
huge
along
amount of
with this
antimicrobial
medicine, we can take
resistance,
or-
always
You can take
practice
it.
antimicrobial stewardship. Always think about the patient, always think about the society, and always think about the bacteria that you are treating. Try and find out what is the mechanism of resistance, what organisms you are treating, what is the source of infection. Choose your antibiotics very wisely and choose the dose and duration also. If you are dealing with the DTR cases, always use combination. That is very important because you need to give antibiotics in having various different mechanism of action. Always try to follow the guidelines, and whenever you are stuck, always ask for help. We are always there. Thank you so much for your patience listening. Always handle antimicrobials with care. This is always my nice slide in all my presentations because we are losing out on antibiotics. We don't have much left right now. Very few are there in the pipeline, and we have to use them very carefully. So thank you so much.
Which one is antibiotic?
This is all.
Okay, doctor. Fever?
This for fever and
Dr. Abdul?
Okay.
Yes, thank you, Sayan, for an excellent talk. Very informative.
Thank you.
Dr. Rajesh, are we going to take the questions now?
No, at the end.
Later. Yes. Now we have got the legendary Professor Subhash Todi, one of the senior most intensivists in the country. Dr. Todi doesn't need any introduction. Everybody in the country in the medical field and otherwise know who Dr. Todi is. By the way, he is the HOD of the Department of Academics and Research, Manipal Hospital, the Korea, editor, Indian Journal of Critical Care Case Reports, past research chairperson, ICCM Research Committee. He has published more than 70 papers in index journals and more than 60 book chapters in reputed critical care books. He has been a reviewer for critical care medicine, IJMM and IJCCM journals.
NDM, 1/3 is OXA plus NDM. Now, ceftazidime active has been mentioned by Dr. Shayan as OXA 48. Bacteria carrying OXA 48 will respond to ceftazidime avibactam. And you know, ceftazidime avibactam is a good antibiotic. It doesn't work against NBL, doesn't work against Acinetobacter, doesn't work against difficult to treat pseudomonas, but it's a very good drug for OXA 48 and definitely for ESBL. So people have been, we have been using ceftazidime avibactam whenever we think it's a carba-resistant infection. But the problem is in the empirical setting, we miss NDM. So is it good enough? Ceftazidime avibactam. And that's why we have been trying to use this
यहाँ पे नहीं कुतनूर में है
what
मैं
is called
फोन नंबर
a ray
देता
of
हूँ
hope.
वो मैडम जो
That
थी
is, if
वो
ceftazidime is resistant, aztreonam is
डॉक्टर
resistant,
भूतमणि
you mix
करके हैं
together
अच्छा
and they become
उनको एक
sensitive.
बार दिखा लो
And that's why
अभी
they
खुला
work
होगा?
in
अभी कितना
NDM. And the
बजा अभी
reason
रहेंगी
is
घर में रहेंगी उनका घर ही
aztreonam
है
is a
वो
good
यहाँ
drug
पे
against
ना
NDM.
अच्छा
but it is hydrolyzed by ESB.
संगम
And
स्वीट के बाजू वाले गली में
is
जाना
the
है।
beta-lactam
पुराना
that
संगम स्वीट
prevents
था
this
ना?
hydrolysis. And Klebsiella is
कुतनूर गए,
usually
कुतनूर
positive
से
in
जो
our country.
गुडविल
So
हॉस्पिटल
if
की तरफ
we
जाते थे,
get
उससे पहले
Klebsiella,
संगम स्वीट था,
not many labs
बड़ा
do
सा
the
अपार्टमेंट के
synergy
अपोजिट में,
test, but
जो अभी
Klebsiella is
नया बन रहा
usually
है संगम,
synergy positive.
पहले जहाँ था
The
अभी वहाँ
problem
पे
comes
कंस्ट्रक्शन
with
चल
E.
रहा
coli
है।
and
उसी गली में
Pseudomonas.
अंदर जाएंगे
They are
तो
usually not synergy
500-600
positive.
मीटर
They may
इधर
be
से जाएंगे
synergy
तो
negative.
लेफ्ट हैंड पे
So
पड़ेगा।
if we get an E. coli
मैं
Pseudomonas
फोन नंबर
during a
देता हूँ,
synergy
गुडविल
test
हॉस्पिटल
becomes
के
very
पहले
important. We
पहले
can get away
लेफ्ट साइड में ही है सर।
without this test by Klebsiella
वो
and use this
पहला थोड़ा सा है, मतलब वो जो
But what is the
अपार्टमेंट
problem
है
with this?
उससे थोड़ा लेफ्ट नहीं
Ceftazidime, Avibactam with Aztreonam doesn't
नहीं,
cover
पहला अपार्टमेंट
Acinetobacter.
ये जो
As you can
सविता
see
के अपोजिट अपार्टमेंट है।
What are the
सविता के
challenges with
अपोजिट
this?
अपार्टमेंट
As you
वहाँ
know,
रोड ही
this
नहीं है
has to
भैया,
be
सविता
given
के
as an
अपोजिट संगम
infusion
सीट है।
simultaneously in
संगम
both the
सीट
arms
उस तरफ
and
चले
in
जा रहे
two
हैं जहाँ
different
ये
channels.
मैं क्या
And
बोल
the
रहा हूँ, पुराना
PKPD
वाला
is not
जहाँ पे अभी
optimized.
कंस्ट्रक्शन चल
They
रहा
have
है,
to give
नया
a
वाला नहीं,
separate
नया
compound.
गुडविल के उस तरफ है,
And
हमें गुडविल
ceftazidime
के
is
इस तरफ
rather
लेना है,
superfluous.
उस
It
तरफ
is
नहीं
what
जाना
we
है।
need is Aztreonam
गुडविल से पहले
and what we need
वहाँ
is
पे कॉर्नर पे
Avibactam.
कंस्ट्रक्शन चल रहा है, उस
Since
पे
we
लिखा
don't
है
अच्छा,
had
ठीक है,
any
समझ
other
गया।
choice,
उस गली में
that's
जाना
why
है,
we
जी।
use
ठीक है,
this
और नंबर देता
combination.
हूँ, वो
But
फोन
now
कर
we
लो,
have
वो
this
लोकेशन भेज
Aztreonam
देंगे।
Avibactam. It is available,
क्या
the
नाम है
prices are
डॉक्टर
high,
रूथ मनी,
but eventually this would come down.
उनको
This
जाके
is a good
इमीडिएटली
drug
दिखा लो अभी।
against NDM, and because it has
ये
Aztreonam, which
8.23
works
है ना?
against NDM and Avibactam,
मैंने सोचा
which
कि
will
आपसे
prevent
पूछ लूं।
वो
hydrolysis of
इन्फ्लेमेशन हो रहा है
Aztreonam.
और ब्लैक क्लॉट
So
प्रेजेंट क्यों
Aztreonam
है,
Avibactam,
वो
it
देखना
doesn't work
पड़ेगा।
against
थैंक यू
Acinetobacter.
सर। कुछ पे
It's a
नहीं,
good
नहीं।
MPL, it's a good Oxa 48, it's
आपका
a
नाम
good
बता दूंगा।
ESBL. So question comes, if we suspect a carba-resistant infection, I think the first algorithm in our clinical practice would be, if I suspect an infection, is it empirical, is it community, or is it hospital? Then we have to choose an empirical antibiotic. As you all know, we have to choose because our first guess has to be right. And there it comes the problem. How can we know that it is a carba-sensitive or carba-resistant? Yes, if anybody has been exposed to carbapenems in the past, exposed to a lot of antibiotics in the past, have been hospitalized in the past and has been in ICU for a long time, we think it's a carba-resistant. But as we know, our epidemiology is gradually increasing in carba-resistant infections. So empirically, we have to be correct. So we need a much better phenotyping of our patients to differentiate carba-sensitive and carba-resistant. So that will be the next
Bedside.
Yeah, so this is a very good question. This practical adjustment has to be done in real time. So once you have a patient with renal, you have to find out what is the creatinine clearance or the GFR, and everyone is using some app where you can get this renal dose adjustment of this antibiotics. You can just check in that, and you can straight away give this. And in CRRT also, the dose adjustment is written over there. You can use that. Now the main question is, this is a very burning question, that what to do if the patient is having sepsis. You give a loading dose and then straight away change to the lower dosage as per the renal clearance, or you give it for 2 days as a full dose and after that you decrease the dose. So I don't think I have tried to find out the answer, but I've never got any answer from the literature that you have to give it for 2 days and then decrease the dose. Most of the time, or everywhere it is written that you give a loading dose and then you decrease the dose straight away. So that is what my practice is, and I have seen that it works. It is not, you don't have to give it for a 1 day or 2 day or 3 day full dose and then you decrease the dose. So I don't know, Gafur sir or Chawla sir, you can maybe speak on this.
I've seen people, particularly a person with urosepsis and multi-organ failure, they do give carbapenem for 1 or 2 days and then decrease. This I have seen. But regarding ceftazidime avibactam, we usually give the loading dose and then decrease. This is and similarly for polymyxin also, the loading dose or colistin loading dose and then decrease. Polymyxin you don't have to decrease in renal failure, but the colistin you have to decrease it. That's another very commonly I have seen people will decrease the polymyxin B in AKI. to very low, which is really not required. We normally give 7.5 twice a day polymyxin after the loading dose of 50 gram. And we've never seen this drug inducing nephrotoxicity. If the polymyxin has to cause nephrotoxicity, it's not dose limited. It can occur otherwise also. What is the opinion of Dr. Abdul? He also must have used many times these drugs.
Rajesh is regarding polymyxin B, isn't it? And cholesterol.
Yes. Polymyxin and renal dose. I don't decrease anything.
Yeah, of course, we should not decrease the dose of in polymyxin B because then we will be underdosing. But polymyxin and colistin, as you all know, are almost equally nephrotoxic. But still, polymyxin B doesn't need dose adjustment
because it doesn't go through the kidney. And colistin you have to adjust, of course.
Of course, yes.
Okay.
I still use a lot of colistin and polymyxin B. Of course, with newer agents too. The next question.
I always try. I asked a question before when I'm writing polymyxin. Do I have other options? Then I write down polymyxin because if I have after CAS-heavy, the dose has definitely. The number of patients we write down because most of the ICUs you will find it is the Klebsiella or E. coli which are creating mainly the Klebsiella. Few of the centers will have Pseudomonas. And crab also comes and goes. Sometimes it is crab. It keeps on varying in our ICU. That's what I have noticed.
My main concern is E. coli, which are resistant to ceftazidime or avibactam, and no Astrionum synergy. And we do have a good number of those E. coli, and where colistin is the only option.
Yes.
Correct. So if my neutropenia patients are really crashing, I'll give ceftazidime, avibactam, Astrionum, and colistin. Because next day I don't want an E. coli which is resistant to ceftazidime, avibactam, Astrionum.
Okay.
Now, given the cost and access constraints for these newer agents in India, how do you prioritize their use? And what role does antimicrobial stewardship play in preserving them? Both of you can answer. Because so many new drugs are coming to the market, including cefepime, zidabactam. How important is antimicrobial stewardship in the country at various levels?
Yeah, so regarding the newer drugs, I will probably not use it as a first line. I will still be using the drugs which are available right now, and if they fail, then probably I will move on to the newer agents like cefepime, zidabactam. So, and that's how I will rather preserve it rather than not using it straight away for all the patients. And antimicrobial stewardship obviously has to be in place at the hospital because indiscriminate use and abuse rather. So that has to be prevented for these newer agents because these are the ones which is going to save lives of the patients when other drugs are not working. So if we straight away use it as a first line, then definitely the bacteria, they are much smarter than us. They are definitely going to find out ways to produce resistance. I've already shown that cefepime zidabactam resistance has been documented. We don't want that efflux pump or the Porin channel or some new mechanism to develop in a bacteria and that becomes a super bug. So yes, you have to use it very carefully.
You rightly said, Sayan. Yes, cefepime zidabactam is a super antibiotic, no doubt about it. One of the best antibiotic ever developed by pharmaceutical industry, but still is an antibiotic. And bugs are definitely smarter than any antibiotic developed by humans. If you don't use it rationally, because cefepime zidabactam is going to be the life-saving drug for the next 10 years. And if you don't use it rationally, we will lose that molecule. However powerful it is, bacteria will develop resistance, and that resistant bacteria will spread in a country like India. That's happened to ceftazidime avibactam. Such a powerful molecule became resistant fast, and we have to depend on Astrionum. Now the E. coli have become the super E. coli and not sensitive. And same situation will happen to cefepime zidabactam, whatever explanation is given.
Absolutely.
Okay. So we can wind up now.
Yes.
Your comment.
Yes, excellent session. Sayan, Dr. Chawla, and Dr. Todi. Amazing. So, you got participants from across the world?
Yes, all over.
Wonderful.
We have close to more than 1,000 people every time.
All right. Excellent session. You're doing a great job in coordinating these meetings.
So,
Thank you all. Yes, Dr. Rajesh, over to you.
Yeah. So with this, I would like to thank Dr. Abdul Ghafoor because he is into this antimicrobial resistance for last many years for moderating this session. Dr. Sain for taking a wonderful lecture on this difficult to treat gram negatives, and Dr. Subhash Todi who had to go and who gave us a brief overview of what is in the pipeline and what is their spectrum, what they cover. And Dr. Kansha for covering beautifully in the beginning the last module recap. So there is one more left for gram negative, and now we are going to concentrate on the crab and crab. One lecture each on them before we wind up the gram negatives. Because I think if you've been listening to all these 4 modules on gram negatives, most of you must have become ID on this, I'm sure, because we're the best of people telling you about this. And then we'll go on to the, so see you next time, the next Tuesday at 7:30 p.m. with the recap. And before that, I would like to thank Hexicon IT team for beautifully conducting this without any hitch, and Limelight Biosciences for supporting this event. Good night, and you can enjoy the India-England match. Thank you very much.
Good night.
Thank you. Good night.